so thrilled to be here and to be joining such a huge crowd to be speaking about this topic. And it's been, I think, maybe over a year ago that I think it was maybe Martha or Sally, and I can't remember which one, who originally reached out to me. And I was so excited to see this kind of come together over this time, and happy to be here. My name's Janna Gordon-Elliott. I'm a psychiatrist here at Cornell, and I'm a consultation liaison psychiatrist. So I work, I'm trained to work in medical settings and have spent a lot of years working in busy academic medical centers with a lot of the complex cases, the most complex of which have been some of the cases with autoimmune encephalitis. And these are the cases where lots of doctors and lots of providers from lots of different specialties get involved, and tempers can run high, and things can get kind of difficult and stressful. And often the psychiatrist gets pulled in for a number of different reasons. And what I'm going to talk about today a little bit is about why things can get particularly difficult for the patient with autoimmune encephalitis in the hospital. I have no relevant disclosures. So what is, let's talk a little bit about the modern healthcare system. So what a lot of the care of a lot of these patients starts in the general hospital, or it peaks in the general hospital. So they may start their treatment in the outpatient setting, and nothing's happening, and eventually the family brings them into the hospital, or their course starts very abruptly with a very acute presentation with autonomic instability, like heart rate dysregulation, blood pressure changes, and they start in the general hospital. But a lot of the time, some part of their management takes place in a large hospital. And so I'm going to be focusing in on the general hospital during this talk. What I'm going to be talking about a little bit are the things that can go wrong in the hospital. So even when we have the best medical providers around, even when we have the top-notch technology, even when we have the most amazing resources available, and even when everybody around has the best intentions, things can still go wrong. And a lot of this actually is related to complex processes. What I'll kind of suggest to you all is that a lot of this is related to some complex processes that exist at both the individual and also at the group level. And some of these processes are even unconscious, and that these things happen especially during very stressful situations that are actually very common in the general hospital. But that these things are actually quite predictable, and that we can see these things happen over time, and that we can anticipate some of these very difficult and stressful situations, and that we can detect them as they're starting to happen, as some of the difficulties are starting to happen, and that we can even potentially prevent them. And what I will suggest as well is that for the patient with autoimmune encephalitis, there's something specific about that gray zone. I'll use that term that Dr. Palanjani used. There's something about the grayness about autoimmune encephalitis that I think particularly triggers a lot of the difficulty that these patients have in the hospital. Something about the overlap between kind of neurologic symptoms and behavioral symptoms. Something about the fact that the course doesn't always follow the way it's supposed to follow. Something about how it's sometimes difficult to kind of nail down the diagnosis or find the right treatment, and that in that context, things cannot always go as smoothly as they should, and things become difficult. Okay, so let's talk a little bit about the modern healthcare system and why it is so particularly complex for all patients, but I think particularly for the patient with autoimmune encephalitis. So what is it like to be in the general academic medical center? And I'll speak probably primarily about kind of tertiary care hospitals, academic medical centers these days. So these are really large systems, getting larger and larger every day as hospitals tend to be merging more and more these days. Care tends to be delivered in team-based ways. Services are highly, highly specialized. People have gone through kind of rigorous training and often kind of provide one very small and sometimes siloed aspect of treatment. There are multiple disciplines, so not only medical specialties, but also disciplines. So you have the physicians, you have nurses, you have people who do physical therapy, occupational therapy. There's geographic diffusion in the hospital, so there's many different floors, many different wings. Everything potentially is connected by an electronic medical record, but people are all over the place, scattered. There is a complex record system, and often even the system isn't combined. And of course, every hospital still these days tends to be on different record systems, and we are still in the process of trying to get into a modern era where those are connected. There is more and more biopsychosocial complexity in the general hospital, more and more as conditions are being able to be managed in outpatient settings. The people who end up in the general hospital tend to be the most complex. These are the patients who really are so complex that they can't be managed in the outpatient setting. And so these are the patients with such complex medical conditions that they were not able to be taken care of as outpatients, or who have significant psychiatric disorders, substance use disorders, or social situations that made it very difficult for them to get their medical care as outpatients. There's complexity of diagnostics and interventions. As technology advances, this is wonderful and gives us more options, but it also means that everything that's being done in the hospital is more and more challenging and difficult. And then, of course, there's also focus on cost and efficiency. So we're trying to save money, or at least watch the bottom line, and to save time. And so there's this opposing pressure. We're both trying to do kind of the very best and use the highest level of technology and push the envelope, but we are also trying to make sure that we're doing it quickly and at a low cost. So the perfect hospital course will go very, very smoothly, of course, right? It involves a high level of knowledge by all the providers involved. It involves a highly well-organized team of specialists who all come in and weigh in on their kind of trained area. There are multiple disciplines who come in and provide the care that they are trained to provide. There's technology that gets utilized. Records are obtained from different hospitalizations in the past. There's communication that is seamless between the teams in the hospital. There is patient-centered care. The focus is very much on the patient and the family. There's diversity of perspectives, ensuring that we are attending to everyone's needs. There's support for the family and caregivers. And then there is also attention to what the plan is going to be after the hospital, and that we're paying attention to that early and often, well before we get ready for discharge. This is the perfect hospital course. Needless to say, this is challenging, if not impossible, to achieve. And the hospital really likes to function in an ideal way, right? So it likes to think that that progress is kind of moves forward, that things are going to continue to go step by step, that there's a plan, and that all the players are pretty much on the same page, that people have pretty much a consensus about what their overall goal is, and that everyone is working towards that goal at the same time. Ideally, that allows the hospital to kind of go along in a way that it feels pretty good about itself, and everyone working for the hospital feels good about the hospital, about what they're doing, and the treatment that they're providing. Then you have a hospitalization where you have a patient with autoimmune encephalitis, and this could be also hospitalization with anyone who's in the hospital, but it's often the case with somebody with a complex medical or psychiatric condition, or who has other complications that make things particularly difficult while in the hospital. And so what are some of the things that can come up that can make a hospitalization particularly difficult for these kind of cases? There might be difficulties at many steps along the line. There might be difficult in terms of the assessment part of the treatment. There might be deficits in terms of the knowledge base, right? So they might even miss the diagnosis. We've been talking a lot about that, how especially in some of the early stages of autoimmune encephalitis, you may miss the diagnosis entirely. There might be deficits in terms of availability of specialists, so you might not have the right kind of specialists available. Or you might have too many people involved. This often happens, where there's too many people weighing in and they all have different opinions and things get muddled up. You might have difficulty with technology, so you may not know that there were old charts, or you may not be able to obtain those old charts from another hospital, either because of lack of access or because you don't know how to get into the old system. There may be difficulties in terms of the management of the patient or the case, so that you may have difficulties with the treatment that's being provided. So there may be inadequate or wrong treatment being offered. So the patient isn't actually getting the appropriate or correct treatment. There may be deficits or problems at the level of communication. So there may be difficulties with communication between members of the team, between the team and the patient, or between teams and other teams and staff. And then there may be difficulties at the level of transitions. So this may be transitions so the patient may be transitioned from one service to another service, perhaps prematurely or perhaps in ways that doesn't allow for communication from one service to the next service. And then there also might be not enough attention towards the final transition, the transition from the hospital to the outpatient world. And there may also not be enough outpatient resources for this patient. So there might not be the ideal idea of this interdisciplinary outpatient autoimmune interdisciplinary program that one of our caregivers suggested, which I think would be wonderful. That we don't have a lot of these kind of resources available to us. Okay. I'm going to just describe two cases really briefly, not to get too much into the details, but more as just examples of cases where things actually went quite well, but where because cases with autoimmune encephalitis can be so challenging, things got halted, they stagnated in some way, and I'm going to then offer my suggestions about what I think went wrong. The first one was a case of a 32-year-old woman. She had one previous psychiatric hospitalization about 10 years prior. She presented with findings that were actually typical of NMDAR receptor encephalitis. And she, here at this hospital, she actually received appropriate acute management. So she was diagnosed appropriately and received appropriate acute management. So I'm not telling the story of a case where she was not detected appropriately. So she got all that treatment correctly here at our hospital. And then she was on the neurology service, and she was treated, but she was very quiet in her room, a lot alone. She was kind of disorganized. She was wandering around her room. She was putting toothpaste on her hair. She would often sit in a corner kind of quietly for hours on end, not doing much. Weeks went by with this way. Her family would say to the team, she's not herself. Several weeks later, psychiatry was consulted for the question of depression. We did a Montreal cognitive assessment, which is one way of assessing someone's cognitive capacities, and she got a score of 12, which is very low. Her history was further clarified, which detected that we clarified a little bit more about this past psychiatric hospitalization that had happened before, and learned that there had been a past diagnosis of autoimmune encephalitis. Discussions occurred among the primary team about whether there should be second-line treatments done for her autoimmune encephalitis. And there were some disputes going on to some extent. There was just differences of opinion about whether it was indicated to try rituximab, for example. And though she was stable and improving, there was some question about, is she as good as she's going to get? And there was question about whether progress was halting. In another case, there was a 21-year-old woman She has no psychiatric or neurologic history. She presented with findings typical of NMDA receptor encephalitis. She was acutely stabilized in the ICU, but she was behaviorally dysregulated and physically disruptive. She had altered mental status. She was, very physically aggressive. Psychiatry was consulted for her agitation. I think that the implicit request was also, please take her to your service because we don't know what to do with her. Multiple psychotropic medications, so antipsychotic medicines and other sedating medicines were being used, and not in a strategic way. So she would get one, and then she would get another, and all in like multiple different doses. In many ways, she had gotten great care. The appropriate diagnosis was made, and she got the appropriate ICU level care for her diagnosis. And on the other hand, the team was now kind of flummoxed and scared and not knowing what to do, and at this point, kind of throwing up their hands and not really, and kind of stuck in terms of how to manage her behavior. And everyone was feeling frightened and worried and asking for help. Okay, so now we'll talk briefly about why I think these cases with autoimmune encephalitis are so particularly vulnerable in the general hospital. So, as we've talked about throughout today, there are many aspects of these patients' cases that make them particularly difficult to manage in many ways. So they have high acuity symptoms, and these are medical, right? So they can come in very medically sick. They can need the ICU. They can be hemodynamically unstable. They can be neurologically very acute, having seizures. They can be falling. They can have other very frightening and worrisome symptoms, and they can have very significant and very alarming behavioral symptoms. They have symptoms that span diagnoses, and I put an asterisk here because hospitals are disorder-based. Hospitals really like disorders. They like things that have a label and that fit into a category, and they don't like things that span that. We started our day with Dr. Weir's talk, which really kind of tried to kind of capture that. We like things that fall into categories, and we don't like things that don't do that. Patients with autoimmune encephalitis or the autoimmune encephalitis in general have complex histories that often don't follow the patterns that we are used to. They don't follow some of the patterns that we maybe as physicians kind of learned in terms of how to do a history on something like schizophrenia, for example, or how to do a history on something like a usual seizure disorder. And the workups can also be quite complex. So what we might have learned 10 years ago in medical school might actually have been updated, and we need to learn more about that. Or actually, what we learned in medical school is not even relevant because NMDA or receptor encephalitis didn't even exist at the time that we went to medical school. And so there's so much to learn. They have an unpredictable illness course and also an unpredictable treatment course. And there are many players who are involved, so many specialists who have to get involved, and that can be confusing and difficult. And also, these are often young patients. I'll go through all those things that I just talked about and describe how I think that those particularly are challenging for us in the hospital. Let's just start with my last point, which was the young patient. Who runs the hospital? In the academic medical center, actually, the people who run the hospital a lot of the time is the house staff. So the house staff are often the residents, but also I'll say that as a lot of the people who run the hospitals are nurses and other staff who are often young in age. And what can happen when you have a young patient is identification. What happens is you see this young person who you identify with because they're young like you. And often there are other things that are similar to you. Perhaps they have a similar background to you, a similar education level to you. And this can be very helpful because it can make you identify with the patient and want to help them more. But this can also be challenging. It can make you become overly involved with the patient such that you may kind of have blinders. You may lose perspective. You may miss things. You may have difficulty focusing on what's relevant, and it may become complicated in terms of how you manage the treatment. And it may at some point even cause you to kind of avoid the care because it becomes too much for you. A lot of this is an unconscious process, but it happens all the time with us in inpatient care. Symptoms that span diagnoses. So this is very challenging for providers. We like things that fit into categories, and when things don't fit nicely into categories, we become very uncertain, even when there was a diagnosis. So even in these two cases where we definitely knew that this was NMDA receptor encephalitis, if they weren't like following the pattern that they were supposed to follow, or if the medications we were giving weren't fixing the thing, we get doubtful and we get scared and we become uncertain, and we don't like that. We like to feel like we figured out what it was and we gave it the right treatment, and it's not getting better, and this causes doubt and uncertainty and fear amongst medical providers, and that's often experienced unconsciously, and it can lead to doubt and anxiety, and this can be felt in a subtle way, but it can build over time. Symptoms that span diagnoses can also lead to kind of this general, or at least is part of this general hyperspecialization that exists across the hospital. So there are more and more of these specialists who are involved, all in their little areas. Everyone who's had their specialized training, and even though this adds to the complexity and the wealth of information that we can gather and bring to the case, it also potentially can become problematic if people become too highly specialized and too focused on their own story. And when things become stressful, that can often happen. And so when things become difficult and stressful, often the hyperspecialization becomes problematic, and the response often becomes something like, well, that's not my job, that's that other person's job, that's the other person's issue. Let's see, complex histories and workups. So when you have a lot of tests to do or a lot of workups to do, that also adds to uncertainty, doubt about diagnosis and treatment. It also leads to exhaustion of resources, and I'm not just talking about money, but I'm also talking about staff gets tired, and I'm also talking about emotional resources. The unpredictable illness course also contributes to uncertainty and doubt, and it also leads to this overall exhaustion. High acuity symptoms, so people who are behaviorally dysregulated or agitated, but also having very significant or having seizures, or who are medically unstable, contributes to exhaustion of resources. And also can, especially if they are behaviorally agitated, can lead staff to feel fearful or feel threatened. And many players involved will add to this exaggeration of hyperspecialization, as well as disputes between teams, and also general fragmentation of care, and then decline of ownership. And then something that we often talk about in the hospital, this idea of turf wars, where people are saying, that's not my patient, that's your patient. Okay. So to sum this up a little bit, what can happen in the patient with autoimmune encephalitis and why they're so particularly vulnerable in the general hospital, a few areas of kind of vulnerability. What happens with the provider? So with the provider can over-identify with the patient, which can have some problematic side effects, which I spoke about. The provider can feel, and a lot of this again can be subtle and unconscious, but can build over time. The provider can feel fear, can feel self-doubt, can feel anger, and can feel demoralized. Stress and a very stressful situation can lead the provider to think narrowly and to not think as broadly as normally would. And the provider can start to feel de-skilled and feel less able to deal with things, even if very well trained. And the provider can start to feel unable to deal with things that he or she normally could deal with. The team, so that's the provider. What does the team do? The team, as a group, starts to disengage from the patient, or may start to avoid the patient, or may eject or throw the patient out. The team may also engage poorly with other teams and disciplines, or may break down. And the system, there's communication breakdown and also stagnation. And so the whole system kind of grinds to a halt. So what can we do? Well, I'll suggest that there are several things that we can do. For all members of the clinical team, we can provide more education, so we can do this in an engaged and creative way. We can bring in educators, we can bring in experts, we can do case conferences, we can teach about the topic. We can engage curiosity, so spark academic interest about autoimmune encephalitis. We can engage curiosity about the person in the patient. So who is this patient? This isn't someone who's just having a seizure or who's behaviorally dysregulated, but this is Joe, and this is a picture of Joe when he's healthier, and this is what Joe likes to do. Bring in the experts from different places. Have a case conference. Do this in person. Engage communication and do this at the team level and between teams and also between disciplines, and do it top to bottom. And have mechanisms for frequent updates and do this as much as possible in person. And then also make sure that you're supporting the system. So make sure that everyone in the system feels like they're a vital player. And make sure that you're also addressing the exhaustion and demoralization and the fatigue, but also and the fear and anxiety that everyone is feeling. This also needs to come from the top as well. I heard a really a nice statement the other day about it was about another kind of complex case, a very severe eating disorder case. And one of my mentors mentioned that one of our senior administrators here in the hospital was talking about this case and said something. She said, in anticipation of this patient coming back to the hospital, and everyone was saying, oh no, we're not sure that we can deal with this patient again. She was so disruptive when she was here, and everyone, no one knew what to do, and all the teams were fighting, and everyone was struggling, and people felt like they couldn't handle it. And the senior administrator said, no, this time we're going to start with a fresh slate, and this hospital, this is what we do. We take care of patients like this. This is how we take care of, this is what we do. And I think that kind of top-down modeling like that, I think, can be very, very important. And I was moved by that, so I wanted to share that. In case one, I think what was nice in the end was that what we actually did was we intellectualized, which is a high-level defense mechanism. So I always encourage that. We intellectualized by calling Dr. Dalmau ourselves. Thomas did that. Thomas is somewhere here in the audience as an intern. He did that. And we got on the phone. We had a nice little case conference by phone. And the effect of that was that we got intellectual. We broke some stagnation. We got excited. We got more information. We realized that there's actually no right answer, but more information is better. And we also realized that this should be hard, that it's not easy for anybody. Progress was still slow for this woman. She was still not really getting that much better, but she was a little bit better. And we were able to start a second-line treatment, and she was eventually discharged to rehab, and everyone felt a lot better. So I'm done. But thank you, everybody.